All right, guys, so here's what we're going to do today. We're going to do this virtual lecture. I'm going to try and present it this way, that way it's as close to like a classroom type experience, maybe a little bit better than Zoom has been over the course of the semester. But the topic we're going to be talking about is diabetes. All right. So first thing, just a quick recap from 463 and also from 462 and also from Patho. Two types of diabetes that we're really talking about here. First is type 1, and then we got type 2. Type 1 is where the pancreas is not able to produce insulin that can be used by the body. Type 2 is where the pancreas can produce insulin. However, it's either not producing enough insulin or the body can't use the insulin that is being produced. Real quick, the reason this is important is because insulin is important in transporting glucose into cells to make usable for regular metabolism. Just to review our reference ranges here real quick. So normal blood glucose, we're looking at about 60 to 100, and this is off our point of care testing, so our finger stick testing for glucose monitoring. For hyperglycemia, we're going to be looking at ranges, our yellow zone, where it's like, okay, you got my attention, it's not normal, but like, okay, is about 100 to 299. Our orange zone, where it's like, you got my attention, but you're probably not going to be dying or doing anything weird on me anytime soon, is going to be 300 to 400. Greater than 400 is really where it's like, you got my attention, I'm probably going to be dropping what I'm doing to take care of that patient first, because that's a high blood sugar. That needs an intervention pretty quickly. One thing to take note of for our hyperglycemia ranges, we've got some pretty large ranges between our yellow, orange, and red zones. So we do have quite a bit of time to respond to these things. Typically, and it's a little bit safer. People don't typically die acutely from hyperglycemia. On the other hand, hypoglycemia, this is what causes real problems for patients, especially in the hospital, where they have different changes in their metabolism that require different levels of glucose and insulin. So we don't even have a yellow zone for hypoglycemia. We go straight to our orange zone, which is 50 to 60. So anything just a little bit below our normal range is like, it's getting serious quick. Anything less than 50 is our red zone. So that's where it's going to be like, I'm dropping what I'm doing and I need to go see that patient first. This number becomes even more concerning when it's accompanied by symptoms of hypoglycemia. Okay? So quick review on diabetes. It also introduces the problems we're trying to solve, either hyperglycemia or hypoglycemia. The drugs we're going to be talking about here is we've got insulin-based therapies and we've got non-insulin-based therapies. So for insulin-based therapies, we've got our Lispro, regular, NPH, and Glargine, and these are listed in order of how rapidly acting they are. So Lispro being our most rapid acting, Glargine being our longest acting insulin. Then we've got metformin, our non-insulin medications. So metformin, glipizide, these are our two most commonly used anti-diabetic medications. Acarbose, and glucagon are going to be the other two that we're going to be talking about today. So first thing we got to do, recognize and analyze our cues based on we get our drug list, what's up with this stuff. So first thing is the treatments are going to be a little bit different based on what type of diabetes the patient has, and our medication list can help cue us into that. Type 1 diabetes, insulin is our primary intervention. It's the primary drug we're going to use to monitor hyperglycemia in these patients. This can be either with single insulins, so short-acting, intermediate-acting, long-acting, or it can be a combination of insulins that we use. So this is kind of like we talked about in Skills Lab, where we can use short-acting and NPH insulin, right? So there's a draw sequence that we need to be familiar with. And we always go clear to cloudy. So we do our short-acting and then our NPH second, right? Other things is we need to be sure that the equipment that's being used for that insulin is safe to be used. So we got to make sure that the drug itself is safe. We talked early on that you never want to give a drug where the packaging is damaged or there's like a loose pill floating around in a drawer, because we just can't be sure that that's even what the drug is, or that it's safe to be giving that drug. And the same applies to insulin. And with insulin, we need to be particularly careful because we're going to be using these big vials, right? These are multi-dose vials. So patients are going to be using this over the course of several subsequent days, meaning that there's opportunity to contaminate these vials. So we always need to look and make sure, does this stuff look the way it's supposed to, right? So what should insulin look like? Well, it should be clear for the most part, unless it's NPH insulin, which we know is cloudy. It does have that sedimentation, and we have to reconstitute it by rolling it in our hands. So we always want to take a look at this, make sure there's no like funk or anything that looks contaminated or dirty on the rubber cap, which is where the needle is going to go in, and then make sure our solution doesn't look contaminated as well. There's no floating materials in there. It's not cloudy, it's not discolored, anything like that. Same thing with patients who use these insulin pumps. These are very common with type 1 diabetics. We always want to make sure that the site where that pump is attached to the patient's skin doesn't show any signs and symptoms of infection, things like that. Other things that patients may have are these guys called insulin pens, where they can dial in the number of units they want to inject and then do that themselves. These, again, are similar to these multi-use vials, and we want to treat them the same way. The thing is, we can't visualize the insulin that's inside one of these pens. So what we need to do is make sure that there's a date when they first used this device, and just like a food product or any other medication product, there's an expiration date on these. So we do need to make sure that patients haven't been using these too long and that the risk of contamination is too high, or that the medication itself is expired. Because a lot of patients use these for emergency interventions. So we do want to make sure that these things are not expired and still safe to use. For our type 2s, we're going to usually have combination therapies. They're going to be using insulin to manage acute spikes in their blood sugar, or like postprandial, meaning like after meals. And they're also going to be using oral medications, which are going to help to keep their glucose levels lower than they would be if there was no intervention applied. And we're going to be talking a lot about these. Super important point to note is that a lot of these medications can cause big problems on the kidneys. So they already strain them. So if we give other drugs or other interventions that are going to strain the kidneys, in particular, contrast media, so things like IV contrast or oral contrast that we give for like CT scans, things like that, we need to potentially hold these medications, the oral medications, for 48 hours before and 48 hours after that scan is being done. So big education thing that we need to do with our patients around that. And we'll talk more about specifically which kind of drugs those are in just a little bit. And for both types of diabetes, type 1, type 2, we're still looking at all the usual nursing interventions, things like lifestyle modification. So diet modification, low carb, low sugar diet, and also exercise. We do want patients to be moving around. It will help to increase insulin sensitivity in those patients. So we do want this to be the most effective treatment so they're not getting more medication. So when we look at our insulins, this is kind of like our big table for insulins. We've got our rapid, short, intermediate, and long-acting insulins. All of these work the same. These are synthetic insulins or non-native to that person. The person didn't make their own insulin. So we're giving them insulin that can be used by the body. The big difference between all of these is the onset times, the peak times, and the duration of action. Right? This is where we get our short-acting, intermediate-acting, long-acting, or our rapid-acting insulins. The kind that we give most frequently in hospital settings is our rapid-acting insulins. This is the kind we give at meal times based on finger stick blood sugars. Short-acting insulin is the only insulin that we give IV. So a lot of times this is given for more emergent situations, because if we're giving an IV medication, we want that to work more rapidly. So this is the only insulin that we can give IV. Intermediate acting insulin It's kind of, a little bit longer on the time frame. We're looking at, like a full shift of coverage with NPH. This is the only one that can be mixed with rapid acting, right? So these two can be mixed. This one is IV, and then long acting can never be mixed with anything. This always, always, always has to be a standalone injection. And usually we give this to patients in the evening because of how the onset works. So when our peak is, even though it says none, there is a time where it's most effective, and we'll look at that kind of on a graph. But the duration is 24 hours. So this is full 24-hour cycle coverage of insulin. For our oral drugs, we've got our two most common, metformin and glipizide. Metformin we'll take a look at first. So this is a biguanide. This is the class of medication. There's several other biguanide medications. They all work very similarly. Metformin is the most common or most frequently used medication. The way this works is it's going to decrease hepatic glucose production. So that's going to be through glycogenesis, that whole cycle. It's going to decrease natural glycogenesis, decrease intestinal glucose absorption, meaning that anything the patient eats, it's going to prevent glucose from being absorbed inside the GI tract. So it's going to keep it in the GI tract so it can be excreted. And then it's going to increase sensitivity to insulin that is in the body. Some patients can be successful controlling their type 2 diabetes only taking oral anti-diabetic medications, either biguanides or sulfonylureas. Our therapeutic effect for both is kind of the same. It's diabetes. Management of blood sugar is kind of the name of the game. So that's what's going to happen with our metformin. Moving over to our sulfonylureas, we've got our second generation glipizide and tobutamide, which is our first generation medications. So the way that these drugs work, the way our sulfonylureas really work, is they're going to be stimulating insulin release from the pancreas. So this means that the body has to be capable of producing its own insulin. So this is not going to be effective for any type 1 diabetics because they're not producing any insulin. It's also going to increase sensitivity to that insulin that is produced. So this is really a great drug for patients who are like pre-diabetic or are really doing a great job with those lifestyle modifications and able to maintain their blood sugars pretty effectively through modifiable things like diet, exercise, things like that. Therapeutic effect, lowering of blood sugar because it's diabetes and that's the name of the game. One quick note is, as with any kind of first generation, second generation we've talked about in this class, we always want to prefer our second generation because there's something better about them, right? Otherwise we'd still be using our first generation medications. In the case of sulfonylureas, our second generation medication has a much longer therapeutic effect. So it's going to last, the duration is a lot longer. So that makes it more preferable for patients. We're going to get better coverage over a longer period of time, which makes that a great one. Then we've got acarbose. So this is an alpha glucosidase inhibitor. What that means, it inhibits an enzyme in the GI tract, and that enzyme delays and reduces glucose absorption. So it's going to slow down the rate at which glucose is absorbed into the body. Not going to prevent it, but it is going to slow it down, right? So that's going to help prevent some of those postprandial or after meal spikes in blood sugar that patients experience, because this is going to be working on the GI tract. So our therapeutic effect, lowering of blood glucose, especially postprandial. Okay? Then we've got glucagon. So all these work to lower blood sugar. Glucagon does something different. So this is pancreatic. So this is going to stimulate hepatic production of glucose from glycogen stores, working to increase blood sugar. So we're not looking to lower blood sugar, we're looking to stimulate glycogenesis in order to increase blood sugar. So this is going to work for our hypoglycemic patients. All right, so those are our big oral drugs. Here's our note sheet. when we start building that out. So we've got our insulins. Really important to know the difference between those types of insulins and are making sure it's safe to give those insulins. So assessing not only our patient, but also our drug. Is the drug safe? Is it contaminated? Is it expired? Stuff like that. Then for type 2, we're giving insulin and our oral anti-diabetic medications. So metformin and glipizide are our two big ones. And again, that contrast media, big deal for patients taking those medications. So then moving on through our nursing kind of clinical judgment into the second part of this. So how do we use this stuff, right? So first thing we need to do is know what type of diabetes the patient has. Fair? Because our interventions are going to be very different. We don't want to see oral anti-diabetic medications for a type 1 diabetic because they don't produce any insulin. So those drugs are not going to be effective for those patients. Our goals of therapy, no matter what type of what type of diabetes the patient has, is always to maintain blood glucose levels within our normal range. That 60 to 100 range is really where we want to keep it as much as we can. This is also, by the way, very unrealistic for patients with diabetes. They have very poor utilization of glucose, so their blood sugars tend to run higher or lower, which is more dangerous. So we want to be as close to that normal range as possible. I often see patients with an average blood glucose of like 150, 170, and we really don't get too bent out of shape about that kind of thing. We do want to try and work with patients to keep it as realistic as possible. But we don't want them in those orange zones, red zones, routinely, because that can lead to a lot of those complications, all the pathies that are associated with diabetes. So oftentimes a combination of interventions is necessary in order to achieve this goal of keeping them as close to that normal range as possible. And this is where we get into using multiple types of insulins. So short-acting, long-acting, or short-acting and very long-acting insulins, oral and injectable medication combinations. So patients who will be taking oral, so for our type 2 diabetics, they'll be taking oral anti-diabetic medications, but they'll still be checking their blood sugars routinely and dosing themselves with some insulin as a way of supplementing what their body's able to do with the oral medications. And then of course, lifestyle modifications. So we do need to do teaching on diet modification, exercise programs that patients are going to do. And just like we talked about in 462, the most important part of any exercise regimen that we recommend for a patient is always something that's realistic for the patient, right? If I treat any patient and say, okay, so here's an exercise program, found it on the internet, it's awesome. It's to help like build muscle fast. So what you're gonna do is you're gonna be lifting a ton of weights, things like that. It's like, this is so unrealistic. Most patients are not gonna go for a heavy weightlifting program from nothing, from a disease state. So we always have to figure out what activities they already participate in. Is there any way to leverage those, or what are they interested in doing to increase their activities? Because our big goal, the way we want to achieve this is we want our patients to be able to manage their diabetes independently, right? We don't want them to be dependent on us to keep their blood sugar in that normal range. Whether it's through injectables, whether it's through oral medications, whether it's through lifestyle modification, we want them to be able to manage and keep their blood sugar as close to that normal range as possible outside of a healthcare environment, because that's where people should be living, is outside a healthcare environment as much as possible. So looking at our insulins again, when we look at how we use these things, rapid-acting insulin is the one that we give most often for postprandial spikes in blood sugar. And the way this is typically utilized is through sliding scale insulin dosing. What this means is based on the patient's fingerstick blood sugar and how high that blood sugar level is, that will equate to a different dose of rapid-acting insulin. So the higher their blood sugar is, the more insulin they get. the lower their blood sugar is above normal, the lower the dose of insulin they'll get. So for example, like a blood sugar of 200 might require 2 units of insulin to be given, whereas a blood sugar of 350 may require something like 6 units of insulin to be given. So that's the most common way that we're going to be giving this drug. And this drug is always given subcutaneously, either in the belly, back of the arm, top of the legs. Those are kind of our most common injection sites. With this rapid-acting insulin, the onset time of this is very fast, very, very fast. So 10 minutes, we could start to see a drop in their blood sugar. So we need to make sure that patients have their food in front of them, ready to eat when we're giving this insulin. We can't be doing this when they call to order food when they're in the hospital, because it can take a lot longer than this time window in order to get that food from the kitchen to the patient. So we could cause hypoglycemia by giving it too quickly to this patient. Short-acting insulin, so longer onset time, much longer peak duration time. And this is the one that can be given either sub-Q, but we don't usually give it sub-Q very often. Primarily, this is the one we give IV. So patients who show up in diabetic ketoacidosis with extremely high blood sugars and metabolic dysfunction that follows with it, we want to give insulin that's going to act quickly to bring down their blood sugar. Short-acting insulin is the one we typically use in order to manage those very, very hyperglycemic patients because we can give it IV very, very quickly in a hospital setting. NPH insulin is our intermediate. So again, our durations of all things, onset, peak, and our overall duration, all of our time windows are getting longer as we move down the list. NPH, we're looking at full shift of coverage. This one is the one that can be mixed. So we can mix this just like we practice in Skills Lab for 462, mixing NPH insulin with Lispro insulin, with our short-acting insulin. The reason we want to do that is we're going to be covering both long-term coverage and meal coverage, but saving our patient from getting 2 separate injections, right? So it's a matter of convenience that we can mix these 2 insulins. And NPH is the one that always looks cloudy. So it always looks, you can't see through it. So you always have to reconstitute it because there may be, all the sediment may fall to the bottom, and we do want it to be reconstituted in that cloudy suspension before we draw it up and give it to a patient. And then our long-acting insulin. So these are going to be the ones that last for 24 hours. We typically give these medications in the evening when we're dosing a patient, and they're going to be independent injections. Usually they're not around meal time, so there's no conflict with dosing patients for a meal versus their long-acting insulin. It tends to work out pretty nicely. These medications do a great job, but because they work for such a long duration, we do not want to mix them with any other insulin because of the danger that their blood sugars are going to become out of control and unpredictable. So we always give these as a standalone injection. And the reason this works is because here's the time frame for what this looks like. Our rapid insulins, quick onset, also quick offset, short duration. Their effect is going to wear off very shortly. And then we're not really talking about Detamir, but Glargine is the long-acting insulin that we're talking about. And you can see it's really not going to have peak effect, even though there really isn't a peak because it's so long, until about 8 hours after the patient takes that medication. So we don't want to give this in the morning, right? Because if we give this at 8 a.m., by 12 hours in, when we're really kind of at our peak, it's 8 p.m. That's when patients are going to sleep. This is when they have the most risk for hypoglycemia. So we always want to dose these patients when the onset, when the effect is climbing while they're sleeping, but the peak effect is when they're awake. That way we can assess them accurately for signs and symptoms of hypoglycemia during waking hours, not during overnight periods where they're going to be asleep anyway. So we can't really differentiate between sleeping and hypoglycemia because that CNS depression is a big side effect or symptom of hypoglycemia. So we want the main peak effect to be during waking hours. That's why this one is dosed in the evening. All right? So here's some of our treatment plans. This is what it looks like when we give combination therapies to patients. Conventional therapy is where we're not mixing the effects of different insulins. We're either using one or the other. So we used to do regular insulin, with breakfast, lunch, and dinner, and then NPH insulin to cover them overnight. So that evening injection is where we would be giving our NPH at bedtime, right? Intensive therapy is more commonly used, especially in acute care settings, so like in a hospital type setting. This is where we use a basal dose of insulin, so this is gonna be one of our longer acting, plus a bolus, meaning that mealtime or postprandial dosing based on their actual blood sugar at that moment. So what this is gonna look like is we're gonna be giving combinations of drugs. So we can see that there's an NPH dose as well as a Lispro dose. So combination here in the morning, and the NPH is gonna cover them through the waking hours, but the Lispro is gonna cover the spike for their mealtime, for breakfast. So we're trying to cover what their blood sugar is going to do in response to eating breakfast. At lunch, we're gonna cover them with just Lispro. At dinner, just Lispro, and then at bedtime, we're going to give another dose of NPH to manage their blood sugar through the night. With both our conventional therapies and our Lispro NPH combination, kind of intensive therapies, this is where we get into that thing we talked about in 462, that Somogyi effect, right? This is where patients become hypoglycemic overnight, but then hyperglycemic in the morning. So the way I look at these scales is all of this kind of beige. This is blood sugar in the body. So we're injecting insulin, so blood sugar goes down. As it wears off, blood sugar goes back up. So here, blood sugar is down. Here, it's back up. We can also see this with our regular dosing where patients become hypoglycemic overnight and hyperglycemic in the morning. It's that hypoglycemia in the evening or overnight that's the most dangerous, because all those symptoms of hypoglycemia, sweating, confusion, decreased central nervous system activity, so decreased level of consciousness. It's very hard to assess decreased level of consciousness or altered mental status in patients who are not conscious. We would much rather have that effect during waking hours, where it's easier to tell if somebody's confused or if they're having a harder time answering questions appropriately. This is why we start using Glargine, which is our long-acting. It's that 24-hour dosing, right? So we give Lispro with breakfast, lunch, and dinner to still manage those postprandial spikes in blood sugar after eating. But we're giving Glargine in order to do baseline coverage throughout the entire 24-hour cycle. So we don't have that Somogyi effect with our Glargine insulins. That's why we tend to move away from NPH, just because if we don't have to run that risk, we really don't want to. So let's shift gears real quick and now talk about our oral medications, that are oral anti-diabetic medications. So the first one we're going to talk about, kind of going back to the ones we introduced earlier on, is metformin. So this is the one, this with glipizide. These are our two most common oral anti-diabetic medications that we're going to be giving for type 2 diabetics. Because remember, part of what they're going to do is increase sensitivity to insulin and try and bolster production. So your body has to be able to produce some insulin naturally. So they're not effective for type 1 diabetics. So for metformin side effects, nausea, vomiting, diarrhea. Part of that is that prevention of absorption of glucose from the GI tract. Anytime we keep glucose in the GI tract, What that is, glucose is a large sugar, so the body's going to move water to try and dilute that. So there is a little bit of a side effect of kind of an osmotic laxative from that water shift into the GI tract. So that's where a lot of our GI symptoms tend to come from, and we tend to see that through a lot of our diabetes medications. Adverse effects, lactic acidosis. So if this gets very, very severe, patients can start to have metabolic dysfunction associated with some of these side effects. So we do want to look out for severe presentations of acidosis in our patients who have metformin. Nursing considerations, again, assess their GI tract. The more side effects that patient has, the greater the risk for having some of these adverse effects can be. So we do want to always assess GI function for some of our patients who are on metformin. This is also the drug that we talked about briefly earlier, where we want to hold the medication 48 hours before patients get any contrast for like a CT scan and 48 hours after. Which sounds great if you know when you're going to be getting a CT scan. In hospital settings, often patients didn't plan to be in the hospital, so they're going to be getting a CT scan without having held their medication for 48 hours prior. So it's very, very common for patients taking metformin that what we're going to be doing is give them the scan because they need it in order to diagnose whatever problem they're having, and then we are going to very, very closely monitor their renal function afterwards. So we're going to be keeping an eye on their creatinine, their BUN, all their signs of kidney function to make sure that some of this acute kidney failure that can happen from the kidney being asked to metabolize too much over too short a period of time, that starts to resolve. We don't want to cause long-term kidney damage. So we're definitely going to be holding this for the 48 hours after. And if possible, we want to hold it for 48 hours before, but for hospital situations, we may not always get that luxury. Moving on to our next category, so we have glipizide and tobutamide. So again, second generation, first generation medications. So side effects of this, hypoglycemia, and also photosensitivity. So we want to be very careful of light that's approaching patients. Some of them can develop this photosensitivity. Other adverse effects are aplastic anemias. So patients can become anemic with long-term use of glipizide. So we do want to be very careful and do some, I shouldn't say we want to be very careful, but as part of like routine monitoring for safety of this medication, we're also going to be checking blood counts, so a CBC, and looking at things like their red blood cell counts, their white blood cell counts, platelet counts, making sure that they're not developing any of these anemias that can happen with this medication with long-term use. So longer duration medications are patients are going to be taking this for a long period of time, hopefully. So fewer side effects are also present. Sorry, let me back up because I'm tripping over my thoughts here. Longer duration is how patients are going to be taking this drug, right? Because they're typically going to be doing this to help manage their diabetes in conjunction with diet modification, exercise therapy, and probably some insulin for postprandial spikes, because both of these medications are for our type 2 diabetics, not our type 1s. So patients are going to be on this for a long time, which is why those CBCs are really important to look out for our aplastic anemias. Fewer side effects. So with any medication, we've got our first and second generation. Our first generation is typically going to be the one that produces more side effects or has some kind of a limited benefit over our second generation medications, and this is no different. The big difference here is that our second generation medication, much longer duration of action for that medication, which makes it preferable. There's also fewer side effects associated with our second generation medication, so we do want to get patients onto glipizide as opposed to tobutamide, but there are still some out there who are tolerating tobutamide just fine. So obviously, if something's working, leave it alone. It's kind of our best course of action. Other big thing that's a contraindication also in nursing consideration is that with glipizide, patients who take this medication while consuming alcohol, so patients who have alcohol dependency issues, or who just like to take their medications with some beer, I don't really know why, but maybe somebody likes to do that. This medication can have an antabuse reaction. No bueno. So an antabuse reaction is it works on a negative feedback kind of loop, so it causes something bad in order to discourage you from a behavior. So in this case, if you combine glipizide with alcohol, that antabuse reaction is like vomiting, diarrhea. It's very severe GI discomfort would be the professional nursing way to say that. It's going to be a hot mess for patients. They're going to need a bathroom, and they're going to need it right away. So we need to educate patients to not take alcohol with their anti-diabetic medication. So with glipizide, no alcohol and that medication combined, especially at the same time. Don't do it. If they have alcohol dependency issues, we probably don't want to be giving this medication to them because of that antabuse effect. Moving on to acarbose. So this is the one that binds with glucose in the GI tract, prevents the absorption. So this is going to work a little bit differently. A lot of the signs and symptoms we're going to see are kind of that osmotic laxative kind of thing. So abdominal pain, diarrhea, again, that influx of liquid into the GI tract to help kind of manage the diffusion of glucose in and out of the body. That's going to cause some of that diarrhea. As far as adverse effects, nothing out of this world. If the diarrhea gets really bad, that would be adverse, but that's one of our side effects. Big nursing consideration with acarbose is you got to take this with meals. And I mean not like insulin where it's like you take it maybe 10 minutes before they start eating, things like that. This needs to be taken when they are eating. This medication acts on glucose in the GI tract. Once it's absorbed, this drug isn't going to do anything to manage that. So it has to be taken while there is food being digested in the GI tract in order to bind it and prevent it from getting absorbed. So the food, the drug, it's all got to be in there having its little diabetes party in the GI tract. Contraindications for this one, malabsorption syndromes. So because that osmotic laxative effect, patients can develop severe diarrhea. If they have other disease processes that cause diarrhea as well, they can have a malabsorption syndrome, meaning that they're just moving food and nutritious material through their body so quickly that absorption doesn't happen. So if we see any signs of very frequent diarrhea, low protein counts if you're checking their blood, things like that, and they have malabsorption symptoms, we probably don't want to be continuing this type of a medication. So glucagon is our oddball out, right? This is to help lower blood sugar, lower blood sugar, lower blood sugar. Glucagon is to increase blood glucose, right? So glucagon is the one that's going to cause glycogenesis. It's going to cause more blood sugar to be available in circulation. Side effects of this, nausea and vomiting. Adverse effects, anaphylaxis, which is always kind of a scary word, right? With glucagon, we don't want to be giving this to patients routinely, right? If their blood sugar is routinely low enough that we need to be intervening to increase it, we need to look at other factors that may be causing their hypoglycemia. Like, are they getting too much insulin, or are they not getting enough nutrition? We shouldn't be monitoring hypoglycemia long-term by giving glucagon to patients. So this is one where if patients need this medication, we need to monitor these patients very closely because they are having a little bit of a crisis going on. They have a metabolic abnormality that is causing a life-threatening complication where we need to increase their blood sugar quickly. Big thing here is when we think about giving glucagon, we really don't give this in hospital settings. It's much more common in outpatient settings, like nursing homes, places where patients live long-term, rehabilitation centers, places like that. And the key thing here is it takes about 10 minutes for this medication to work. So we need to be assessing our patients, and these need to be safe to take a medication orally so that they have time to have this effect. If a patient doesn't have, if they lose consciousness, for example, because of their hypoglycemia, obviously taking a pill is not going to help them. So that might be more of an emergency, like call 911 type of emergency. And let's talk about hypoglycemia for just a hot second here, because hypoglycemia is the scary thing that happens to diabetics. It is what kills them fast. Hyperglycemia is still really harmful to patients, but usually it takes a lot longer for patients to have a very negative outcome of hyperglycemia than hypoglycemia. We have a lot more chances to intervene with hyperglycemia than we do with hypo. So recognition of hypoglycemia is a really, really big deal for any of our pre-diabetics or diabetic patients, regardless of type 1, type 2. A lot of those symptoms that we're looking for, mental status changes are the ones we're going to see first. So something about their kind of central nervous system function is not going to be happening appropriately. So these are things like their mood is going to be weird, right? They may be much more like, whatever, don't care, much less engaging than they would be normally. Their affect may be depressed. So you may have to kind of like redirect them to answer your question appropriately, is a common thing that I see around affect. And level of consciousness is depressed. So these are patients who need to be reawoken in the middle of a conversation. They're not able to follow and participate with a conversation very well. These are all very, very negative CNS symptoms that are highly indicative of hypoglycemia. Some of the other physiologic things we want to look out for, shaky, so neuromuscular, they're going to be kind of shaky, like fine tremors, and also cold sweats, so cold, clammy, sweaty skin. You touch their skin, it feels like they've been standing outside in a snowstorm, and they are wet. Wet like they just got out of the shower. It is creepy. So they are cold and wet and shaky. That is all bad. So we need the more symptoms that a patient has around hypoglycemia, the worse the situation is. So when we talk about our interventions, this is where we are when we check their blood sugar, and we need to tailor our interventions to match the patient presentation. So glucagon is awesome if we have it available and we have time, right? Because we have a 10-minute onset window, and our patient has to be conscious enough to follow directions, like take this pill, swallow some water. We need to trust that they can follow those directions appropriately in order to ingest that medication. For D50, this is most commonly what we use in the hospital for patients who have severe symptoms. So a lot of this kind of stuff, and we do not trust them to follow directions to correct their blood sugar with oral nutrition. We are going to inject dextrose 50%. And this will start to work within a minute or two because we're injecting usable sugar into the bloodstream immediately. And when I say like push this on a patient, hard and fast is kind of the idea, but you're never going to be able to achieve it because this stuff, to inject it, it is like pushing syrup through a syringe. I mean, it is a two-handed injection. One to hold the syringe, the other to push the plunger as fast as possible, and as fast as possible will be a slow and steady delivery of the medication because the viscosity is so thick on this stuff. So that's what we're going to be doing for patients who are not conscious, not able to follow commands. In the hospital, I don't actually see glucagon being used quite as much. What we do for patients who are still conscious and able to follow commands is we tend to intervene with nutrition before we intervene with injectable medications. So some of the most common things that are available in like the kitchen on every nursing unit: apple juice, orange juice, so simple sugars that can be ingested quickly. And those will start to have an effect on the hypoglycemia, so start to correct that usually within like 2 or 3 minutes. So very, very quick onset for things like orange juice. The problem is that they'll use it up very quickly as well. So we need to follow that up with something that is more complex, more carbohydrate based. So one of the things I often do is I come in with orange juice in one hand, graham crackers in the other, and as soon as the orange juice starts to wake them up enough to follow commands more effectively, tell them what's going on and say, eat all these graham crackers right now, and wash them down with more orange juice. Because we want to correct this hypoglycemia as quickly as possible. So that's one of the interventions that I tend to see most effectively. And it really depends on whether your patient is conscious or not. If they're unconscious or untrustworthy because of their depressed central nervous system status or kind of depressed affect, we want to go to our injectables. If they are trustworthy, they can follow commands, then we're going to try and do this with nutrition rather than injectables. One quick note if you're pushing D50 on a patient. Our onset time is going to be very fast because we're injecting this through an IV, but our duration is also going to be very, very short. So usually if you're pushing D50 on a patient, it's not a one and done type intervention. We're usually going to need to do this 2, maybe 3 times. So the same kind of rules apply. Is when you're pushing this, when your patient wakes up enough to start becoming trustworthy again, we want to give them some kind of oral nutrition, some kind of carbohydrate to help keep their blood sugar elevated over a longer period of time, because we are not out of the woods once we get their blood sugar back up from pushing D50. Odds are they're going to use up all that D50 we injected and then be hypoglycemic again. So do be careful with your hypoglycemic patients. Here's the second half of our notes, and that's all of our diabetes presentation. Here's our complete notes page. As long as you guys are familiar with a lot of what's going on here, you're going to be in great shape for this topic. As always, if you have any questions about the content in this presentation or questions about the material, please feel free to reach out to me, email, text, whatever seems appropriate to you, and I will see you guys next time.